We're live.
Welcome to the Healthcare Transformation Task Force's webinar, New Model Primary Care. This is part of our ongoing webinar series, Achieving Value Through Transformation. I'm Jeff Miklas, the Executive Director of the Healthcare Transformation Task Force based in Washington, D.C. I'll be your moderator today. Before we begin the webinar, I will take a moment to orient you to the Zoom webinar platform. If you would like to ask a question to our presenters, or if you have a technical concern, please type your question or concern in the question box on the Zoom screen. Our team will be tracking the questions that arise, and during interludes in the presentation, we will select questions for presenters to answer. We will have a formal Q&A at the end of the presentation, where you will have an additional opportunity to send in questions. This webinar is being recorded and will be posted to YouTube and our website within 24 hours. We will send you an email once the materials have been posted. Next slide. With that, I'd like to get started by introducing today's esteemed panel. Again, my name is Jeff Miklas, and I will be the moderator. First, I'd like to welcome Dr. Farzad Mostashari, co-founder and CEO of Aledade, an innovative organization that partners with primary care providers to help them transition from fee-for-service to value. Dr. Mostashari is the former National Coordinator for Health IT at HHS and served as a distinguished expert at the Brookings Institute. Prior to his work at ONC, Dr. Mostashari founded the NYC Primary Care Information Project, which equips 1,500 physicians in underserved communities with electronic health records. Thank you for joining us today, Farzad. Really looking forward. I'd also like to welcome Dr. Michael Munger, President of the American Academy of Family Physicians, which represents 129,000 physicians and medical students nationwide. Dr. Munger is a practicing family physician with St. Luke's Physicians Group in Overland Park, Kansas, where he also serves as the organization's Vice President of Medical Affairs for Primary Care. Dr. Munger has been in practice in the Kansas City metropolitan area for 30 years and has served on numerous boards and commissions. We appreciate you being here today, Dr. Munger.
It's my pleasure. Good afternoon.
Great. Now for a brief overview of the topics we'll be covering today. We will be looking first at the Advanced Primary Care Alternate Payment Model that has been advanced by the American Academy of Family Physicians and has recently been considered for approval as a recommendation for testing to HHS. And then next, we'll turn to Dr. Mostashari to talk about Aledade and their perspective on the landscape of primary care payment innovation. We'll follow that with a Q&A, and then we'll also talk about an upcoming webinar that we have scheduled in our series. But just at the top, for those of you who may not be familiar with the task force, we are a consortium made up of patients, purchasers, providers, and payers who are looking to accelerate the pace of transformation to value-based payment and delivery system reform. Our payer and provider members commit to having 75% of their business operating under value-based payment arrangements by 2020. To give you a sense of our membership, we will now show you a slide with our membership logos, highlighting our unique competition of what we call the 4 Ps, who are all committed to the movement toward value. Very quickly, our guiding principles outline a financially and operationally viable and sustainable approach, both looking for reasonable returns on models to keep investments going while also serving the safety net, fostering transparency, and designing programs that effectively move forward the AAA. And with that, I'd like to introduce our first speaker, Dr. Munger, to provide a brief background on the American Academy of Family Physicians and walk us through the organization's Advanced Primary Care Alternate Payment Model proposal. Dr. Munger?
Thank you, Jeff. We can go ahead and go to the next slide. So the American Academy of Family Physicians represents 129,000 physicians and medical students nationwide. We're the only medical society that's devoted solely to primary care. Now, if you look at the slide here on the left-hand side, you really see our member value statement, what we deliver to those of our members. Now, we do that through 4 key areas, as you see on the right-hand side of the slide, through payment reform, and especially through payment reform, we're really looking at standardizing and harmonizing administrative requirements, reducing administrative burden, and ensuring appropriate valuation of the services that we deliver. We also work on practice transformation, where we have practical tools and resources to help all family physicians, regardless of their practice type and style, and really to work to sustain highly functioning primary care practices. We also have intense efforts through workforce. We're committed to growing and supporting the family medicine workforce, understanding that our country as a whole, our health system is short on primary care physicians, and we really need to have a good, sound strategy to increase the primary care workforce moving forward. And finally, through clinical expertise by delivering evidence-based education, research, and training programs to help family physicians, provide excellent team-based care to their patients, families, and the communities. Family physicians conduct 1 in 5 total medical office visits in the United States this year, 48% more than the next closest specialty. And we provide comprehensive, evidence-based, cost-effective care dedicated to improving the health of our patients and families. Family medicine is a cornerstone to the healthcare system. Go ahead and advance to the next slide, please. Now, after the passage of MACRA, and when they allowed as part of that the implementation of physician-focused payment models, the Academy came together and really set about to determine what would be an ideal alternative payment model for our members. Now, based on that discussion, we determined that the APM would need to do the following things. They really would need to promote patient-centered care and delivery. With our leadership in the medical home, we knew that this had to be foundational. We also looked at the fact that this model would need to increase the investment in primary care. Currently only 6% of the total healthcare spend is on primary care, and our belief is that it should be at least double that. We needed to make sure that we could expand access to a multi-payer primary care advanced APM. Now, we've seen in the system today that there are some smaller demonstrations, but they're available only in select regions. And we really wanted an APM that could be accessed all across the country in all areas that would be beneficial for both large system-based practices as well as small independent private practices. We need to make sure that we were going to continue to transition primary care payments away from fee-for-service. We know that fee-for-service has long undervalued the care that we delivered and really doesn't fully capture what we do in managing patients and managing a population. And finally, but most importantly, we needed to make sure that we would reduce physician administrative burden. In this most recent membership survey in 2017, the #1 thing that our members told the Academy we could do for them was to decrease the administrative burden that they were under now, which interfered with meaningful patient care. So we took all of that into account and said, this is something that we were going to need to incorporate in whatever we put forward. We can go to the next slide, please. So once we decided what was important for the APM, we set about on a journey to submit our proposal to the Physician-Focused Payment Technical Advisory Committee, or the PTAC. Now, this is the committee that was formed under MACRA to be able to receive all these physician-based alternative payment models, see how they would accomplish being in an alternative payment model, and then suggest that to the Secretary of Health and Human Services, those models which they felt met that need within the quality payment program. We went ahead and after quite a bit of work, were able to submit our proposal in April of 2017. Between April and when we made our official presentation at the PTAC in December, we had much interaction with the PTAC members, and we used that as an opportunity to refine and evolve our model moving forward. In December, we presented the model to the PTAC, and at the end of that presentation, we were awarded a recommendation for a limited scale testing. Now, limited scale testing, according to the PTAC, would be on a scale at least similar, excuse me, or greater than CPC Plus is currently in its 18 regions and over 5,000 physicians participating. Also, I'll say that with that approval for testing, it became the largest APM in terms of scope and those that it would impact ever put forth at this time. The PTAC will be sending that recommendation to the Secretary of Health and Human Services later this month, and we'll be awaiting that decision for implementation. If you go to the next slide. So if you look at, well, how does this advanced primary care alternative payment model work? Well, it's envisioned as a multi-payer model that will build upon and improve the concepts that have already been tested in other models, such as comprehensive primary care and the comprehensive primary care plus pilot that's going on. As I mentioned previously, it was designed in mind that you don't have to be in a large group practice or a system in order for this to be successful. This will be adaptable for the smallest of practices, the solo practice, small independent practices, and really allow them the ability to expand the care that they're delivering. It will work very well with other alternative payment models such as ACOs or clinically integrated networks. And the other thing to really point out is the how large the scale this really is. This would be something that would be open to almost 200,000 primary care physicians and impacting the care of over 30 million Medicare beneficiaries. So the scale is really broad and comprehensive in regards to that. If we can go to the next slide. So a little bit of a detail here in terms of how is this payment model set up. It's a blended payment model with 4 main components. So on the slide, if we start at the top left-hand corner and then we'll move around the slide clockwise, the first component is that of a primary care global payment. Now this is a per patient per month payment that will be delivered on a monthly basis to the practice. It's going to be a prospective risk-adjusted payment based on the attributed patient panel. And it will cover that defined set of primary care, face-to-face, E&M services that are delivered. It's meant to be delivered in that way so it's not tied to that strict fee-for-service, bottom on an exam table, got to drop a code, but yet will be utilized by practices to be able to be innovative in the way that they deliver care. You know, not just the face-to-face, but, you know, think about group practice or group visits. Think about the ability to incorporate telehealth into your practice. So the ability to deliver care across a broader range of settings will be encompassed by that. Now, if we move to the next bucket on the payment model, that's the population-based payment. This is also a per patient per month and prospectively risk-adjusted payment that will be paid out envisioned on a quarterly basis to a practice. But that's really meant to cover that non-face-to-face patient services, those things that we're doing daily and have little little value added to them right now. Things around care coordination, all of the non-patient facing things that we're doing, but yet involve the care and management of our whole population. Moving then to the next one, you see fee-for-service payment in the lower right-hand corner. And there still is a component of fee-for-service as part of this overall model. There are those things, mainly a lot of the procedural services that really can't adequately be addressed in the global primary care payment. And yet we feel that there still should be the ability to submit a code and have fee-for-service for that aspect of the practice. Again, enhancing the comprehensiveness and the ability to manage the patient within the primary care sphere. And then the final aspect of the blended payment is on the performance-based incentive payment. That's going to be paid prospectively quarterly, but reconciled annually. And this is really, if you will, the at-risk aspect of this. This is performance-based payment that's going to be based on achievement of quality measures as well as some utilization or cost measures, envisioning that the quality measures would be similar to the quality measures that are seen within the MIPS program in the quality payment program. And so that's an aspect that's also included overall. We can go ahead and go to the next slide. So I pointed out earlier, certainly our members are quite concerned about administrative burden. And if you look at this alternative payment model within the scope of what could it do to help members, yes, it's the blended payment. Yes, there will be an increased spend in primary care through this, but also it has some real opportunity to decrease the overall administrative burden. One of the things is with that primary care global payment, it's no longer going to be tied to E&M coding, but more of a prospective payment. So therefore, all of the 95, 98 documentation guidelines that we're all having to go through to turn in the 2.5-page bloated note to get a level 4 visit, that's all out to the side. Now you can actually have true, meaningful notes to really enhance patient care. You're going to have reduced claim submission for some of the other services that many primary care physicians are submitting now, especially around transition of care management and chronic care management codes. And in addition, instead of the current requirements of documentation around chronic care management, it can really be more streamlined and be more meaningful note that you can put into the chart and utilize in order to manage the care of the patient. Also mentioned previously, you really have the ability to go away from the traditional face-to-face visits and really be able to deliver care in a variety of different settings and venues and points of contact that I think would be beneficial. Measure harmonization through a multi-payer aspect of this and use of the core measure set will also simplify reporting and requirements and help reduce the burden. And then finally, self-attestation, which we'll get to in the next slide, is a part of the application process for practices is much less burdensome than what's currently required with a lot of other third-party payers or with some of the other current pilots going on, especially around CPC Plus, having to do quarterly attestation around clinical delivery requirements, things along those lines. So overall, really being able to look at this and saying, not only is it a different way of payment, but it's also really trying to help primary care practices move forward and be able to manage patients without as much of the administrivia that we're all subjected to today. If we can go to the next slide. If we look at one aspect that's also somewhat and maybe not unique, but I think a real highlight of this alternative payment model is around the patient attribution methodologies. And we all understand attribution. It's a discussion that goes on every time we turn around, but we also know that it's critical to any sort of payment and quality and cost performance measurement. And so based on the 2016 Healthcare Payment Learning and Action Network white paper on patient attribution, the gold standard, which they deemed to be patient selection of their own primary care physician, was our gold standard and the first step in patient attribution. Then you see if the patient has not selected a PCP, there are other steps to go through as listed on the slide based on, the plurality or the most recent wellness visit that was dropped, then patient could be attributed to that physician, or the plurality of all other E&M visits if a wellness visit has not been done. Or finally, the final step would be around looking at the number of other claims related to medication, related to durable medical equipment, lab, etc., that were primary care based, and a plurality of those. So again, multiple levels of attribution possibility, but keeping that gold standard of patient selection, trying to keep this patient-centered as we're moving forward. And if we go to the next slide. So that is where we're at. As I mentioned before, we've made our presentation to the PTAC, their official recommendation of acceptance of this alternative payment model for limited scale testing. Will go to the Secretary of HHS, hopefully anytime now. We're waiting for that. We'll then wait to hear the official response from the Secretary to the PTAC, and if the Secretary agrees this is worthy of moving forward with, AAFP stands ready and is going to roll up our sleeves and work with CMS to implement, improve, and get things moving forward in that direction. And so that was a pretty quick overview on something that was a long time in the process. But with that, I'll go ahead and step aside and turn it back over to Jeff.
Thank you, Dr. Munger. It's great to hear really kind of the fruits of your labor. It's been a very busy year for AAFP. We were excited to witness the good outcome at the PTAC. I just want to reiterate what you had said there. That's really important that that we kind of watch for the recommendation from the PTAC to HHS. The task force, a couple of our different work groups have discussed the model this week and certainly want to weigh in support of advancing primary care. So looking forward to being part of that. Before we go on to our next speaker, we did have one question come in, so I'll ask this of you, Dr. Munger, at this point. What has been the uptake from payers in developing a model similar to the one described in the private sector?
So we have, we've heard anecdotally of some other areas of the country that have done something somewhat similar. And at this point, it looks like it's been received very favorably. And I think that's something that we're quite excited about and ready as moving forward to be working with the payers and really messaging the value of this.
Great. Well, thank you. Well, with that, we'll go ahead and turn it over to Dr. Mostashari to provide background on Aledade and his perspective on the primary care landscape. Arma?
Thanks so much. So I first off want to give so much credit to the Academy for being really one of the best organizations that represent the views of their members in Washington. When I was the regulator on the health IT side, they really had the ability to bring the experience from the front lines, but also be able to understand what the regulator and the policymakers' goals are, and to adapt the two to each other. And it is really seldom appreciated how difficult it is to pull that off. And they do it really better than almost anyone that I know in healthcare. So I'm going to offer some comments, and this is from the perspective of someone who's been kind of thinking about how do we achieve these goals, these kind of societal, public policy, public health goals, population health goals, for a long time, and have really always found myself gravitating not to the big institutions, but to the smaller practices, and in particular to primary care, as the key to this all. But for many, many years, almost decades, I really thought that we didn't have to talk about money, and that we could just, talk about health, and we could talk about quality and outcomes and so forth. But that is not the way it works, that you cannot expect people to go broke doing the right thing. And particularly in smaller practices, people are business owners as well as caregivers and providers. So paying attention to the payment model in healthcare is incredibly important. And in many, many ways, the truism that, you get what you pay for is just that. It is true. So let's walk through. We've had the opportunity at Aledade. We work with over 1,500 full-time primary care physicians in 20 states. We're expanding to 5 new states this year, with one mission, which is to help them navigate this transition from fee-for-service payment models to value-based models, and to really thrive in those. We typically start with the Medicare ACO models, but we are now in two-sided models. We're in track 3, track 1 plus, track 1, and about a dozen now commercial contracts that we've negotiated primary care payments for, and Medicaid and Medicare Advantage. So we have seen it all in terms of how health plans have thought about creating that alignment of incentives with primary care. And let me tell you, there's a lot that is, I think, a lot of improvement that, shall we say, that could be made. And let me just march through the layer cake, to mix analogies a bit, okay? The layer cake of how payment to primary care can be made, and just a few comments on each. I do apologize that you have to listen intently, because I do not have the crutch of slides to help you relax your brain and just look at the slides. When I first joined the federal government, they told me that all my slides had to be cleared weeks in advance. And I said, well, what if I don't use slides? What if I just talk? And they were totally befuddled. And so from then on, I have not needed to get clearance from anybody, because there's no slides. I'll just talk about it. But it does put more of a burden, I'm sorry, on you to really be thinking through, and possibly even taking notes on questions you might have. So the base layer here for most primary care in this country, outside of a few pockets, is the system that we live in. The water that we can't even see all around us is the fee-for-service payment system that Dr. Munger talked about, the 99213s and 99214s. And, a lot of our docs, at the end of the day, the most important thing they want is just pay me more, right? Like, just give me parity, a little bit of parity, right? And I find that a lot of health plans, a lot of the negotiations around PMPMs and all sorts of different devices, it's not really about aligning incentives. It really ends up being about finding another way to pay more to primary care. And my view on that is, if you want to pay more to primary care, let's pay more to primary care. Let's make it so that primary care can actually have a thriving practice. Let's just pay more, instead of having the complexity of a lot of the other types of payment models that follow. And in particular, one area that I find just so penny wise, pound foolish, is when payers pay independent practices a fraction of what they pay practices who become part of consolidating health systems. For the same service done by the same people, oftentimes in the same location, whether it's Medicare with facility fees for practices to get rebadged as outpatient, off-campus hospital outpatient clinics, or payers, commercial payers, who will pay a primary care doc, 50% more once they join the consolidated health system. And yet they complain about the pernicious effect of consolidation on patient choice, quality, and cost. So the first part of this is, like, let's not confuse what we're doing here. If we just want to pay more for primary care, let's just pay more for primary care. And let's take that head on. The second kind of payment that comes in is, we want to encourage certain services more, right? We think that traditional, E&M visits don't allow for care management, transitional care management, wellness visits. There's certain things we want more of. So we're going to create this new kind of code that you can bill for. The challenge with those is, again, you never escape. It's almost like, is there such a thing as, quote, good fee-for-service services? There's no service that can't be abused, that can't be overused or underused, given how profitable it is. So the second you put out a new code out there, chronic care management, anyone with 2 chronic diseases, 60% of your patient population qualifies. If you're viewing this as a money-making opportunity, then it makes sense to hire a care manager and have 60% of your population receive care management, $42 a month. But that's not really the intent here, right? That's not really the goal. The goal is that people who really need it receive it. We found in our analysis of even transitional care management that individuals at the highest risk quartile, the number needed to treat to prevent one readmission was 7.7. That's a wonderfully efficient, effective thing to do. But if you look at the lowest risk quartile, the 66-year-old with an elective knee replacement who went home, doing a transitional care visit on that person, it requires 110 visits to prevent one readmission. That's not worth the primary care practice's time, it's not worth the patient's time, and it's not worth CMS's money. So why are we paying for these things as generic codes, TCM, CCM, AWV? One would think that, you could continue to tweak these by saying, okay, we'll pay more. We'll pay you $100 for a TCM on an uncomplicated patient, and we'll pay you $250 for someone with a complicated patient, right? And you can try to draw those distinctions between that. It does add complexity, though. So you can fine tune it. You can pay more for individuals in which it is more indicated, as we've seen, for example, with care management fees in the CPC Plus program. But it still adds complexity to the story. Speaking of complexity, here's the third layer of the cake: quality measurement. We had one of our groups of physicians so frustrated with the burden of quality measurement that they actually turned down a commercial payer's value-based contract. And they said, we will take less money because we don't want to jump through the hoops. It's not worth it to us. That, to me, is a real wake-up. There should be a real wake-up moment for payers, for Medicare, for the quality measurement industry, that the disconnect between the physician's perception of value in these quality measures and the degree to which they're being used is totally out of whack. And, I think that the idea that by creating pay-for-performance incentives, where what you do now, looking back 12 months on something that is mostly data collection oriented and a bunch of box checking that it often happens, that it's then 2 years from now, you get graded on some curve, and then, some opaque equation tells you whether you're going to get paid $1.03 on the dollar or 98 cents on the dollar invisibly. That kind of stuff is, almost like guaranteed through behavioral economics to not work to change physician behavior, anyone's behavior. And so why are we doing it? And it seems to be we're doing it and everyone's doing it because that's just what we do now. That concept of pay for performance has now taken such hold that it's very hard to get commercial payers and Medicare to move off of the idea that this smorgasbord of quality measures is really what we should be basing payment on. So we had the opportunity to work with a very friendly, very innovative health plan as we were co-designing a payment model for primary care, a Medicare Advantage plan. And it was a fascinating experience, really putting ourselves in the shoes of the payer who really wanted to align incentives and have an equitable share. And what we ended up doing was we picked 3 clinical quality measures. 3. That's it. Just 3. And those quality measures were blood pressure control, A1C control, and statins for individuals who needed it. And even that, I'm sure some will quibble with. But for primary care, I think those are pretty good. And the goal should be that those come out of the exhaust of providing clinical care, that the blood pressures you measure are what comes out of NQF 18, out of the EHR, that the A1Cs you get back from the lab are what go into that, and with the meds you prescribe, all that seamlessly flows through, and there's not this box checking exercise going on. That to me would be the ideal. Of course, every time you propose something, everyone says, well, we can't just have 3 measures. What about the person who only treats X kind of patient? But as one of my colleagues who used to run Medicare said, I can make it simple or I can make it fair. You pick. And at this point, I think a lot of docs would rather some small degree of that this measure doesn't quite fit my practice over the advantages of simplicity. So that's the third layer of the cake. Pay me more for high-value services or particular services, these quality, pay-for-performance type approaches. The fourth layer that is now more and more commonly seen is these PMPM payments. It could be an add-on, care management fees, care coordination fees, PMPMs added on. CPC Plus offers quite substantial add-ons to that. Or you could go all the way and go to basically primary care capitation, where there's no longer for that payer, for that patient, a fee-for-service, encounter-based fee-for-service payment. It all goes to PMPM. We asked our doctors about, when we were designing this, what we hope would be a model payment scheme, we said, well, what would you think of just giving you a primary care cap? And one doc who told me he's a refugee from New Jersey, is the way he described himself, in the days where they did a lot of capitation, said, I don't want a cap. And I said, well, why not? Wouldn't it simplify your work? And he said, okay, here's the thing. First of all, if this is just for 5 or 10 or 20 or 50% of my patients, it doesn't actually reduce my need to have a billing team and all the billing codes. And it just introduces 2 separate ways and complexity in how I get paid. So on the one hand, I'm not getting the benefits of that. On the other hand, what I've seen is that you can misjudge how much care an individual needs. And if you set my PMPM, I'm worried that 2 things might happen. One, I get sick patients who need a lot more visits and I lose money. Or 2, I get greedy and I try to sign up too many patients to get the capitation, and then my quality of life suffers and my patient care suffers. So I was surprised that there wasn't more, and I know that there are some practices who absolutely would love to flip the entire practice to being paid on a capitated basis, but the halfway step, I'm not sure how much reduction in burden that provides. The other, again, the other challenge that folks bring up is many of the PMPM type payments have strings attached. I know that in our CPC Plus practices, there's a really substantial amount of money. Sometimes people actually have trouble spending the money, and there's a lot of oversight that has to be there if it's CMS is just paying the money, but it's quite burdensome to account for collecting paychecks of people to prove that you're actually using the money in the right way. So pay more for high value services, quality bumps, PMPM. Nothing really is a panacea, and a lot of models tend up blending these. But we have yet to talk about what I think is actually the most important part of a new model for primary care payment innovation that has emerged more and more in the past several years, which is accountability for the total cost of care. Now, we just heard primary care is on Medicare 4%, overall 6% of the total cost of care. And it sounds compelling to say it shouldn't be 4 or 5 or 6%. It should be 7 or 8 or 9% of the total spending on healthcare. And I have yet to meet a primary care doc who didn't believe that if we just increased that, if we just went from 5% to 8%, that it would reduce cost on the other 95% of healthcare, which some doctors would say are the failures of primary care. It turns out, though, that doesn't just happen. Just paying more for primary care, whatever bells and whistles you put on it, doesn't automatically reduce healthcare costs. Actually, reducing healthcare costs in these other areas, is complicated. It's hard. It's our business. We have 21 ACOs now doing it, and I can tell you it is a brutally hard thing to do, and you're not just going to stumble into it just by paying primary care more. Those primary care providers can absolutely be the beating heart of effective, value-based, high-value, high-performance care, but they have to have the information and they have to have the incentives to actually care about not just delivering fantastic care within their offices when the patient shows up, but actually thinking about how do I invest as much effort and thought into preventing one hospitalization as I do in 50 office visits, because that's the approximate amount of value you can create from preventing one hospitalization, one $10,000 hospitalization, compared to a whole bunch of E&M office visits. That doesn't just happen. And if there's one, we advocated pretty hard when the CPC Plus program was being rolled out a couple of years ago, and they said you can't both be in a CPC program and be in an ACO. And we thought, well, that's exactly the wrong approach. The CPC payments provide the ability for practices to take on the extra effort and intensity of primary care to be able to take on total cost of care contracts. But what we don't want to do is to take primary care out of caring about the stewardship of the total cost of care. And in fact, being able to reap the value they create in reducing hospitalizations, unnecessary waste, cost, complications that we all know is rampant in the system. So what does that mean, practically speaking, for primary care practices, particularly smaller practices in this new landscape, where if we want folks to be able to focus as much on preventing hospitalizations as on delivering excellent primary care when the patient's in front of them. I think the one thing it implies that I didn't quite understand when I was focused on a lot of the quality measurement work and so forth in the federal government was the need to have it be a group of practices that band together and to pool, as it were, their patients, pool risk, and do so voluntarily, not be lumped in with people who you don't know, or maybe you do know and you don't want to be lumped in with them, who are all part of some big baggy collection, but to actually be able to choose your team and to come together and to cooperate and to compete and to see each other's data and to be in the boat together that rises and falls together with mutual accountability on each other. And that is a very powerful aspect we have found in the primary care, accountable care organizations that we have helped support and bring together. They care very much who joins the club, and they care very much that everyone pulls their weight. That is, I believe, a huge predictor of success. It also gives you the ability to have actuarially sound number of patients to be able to take on risk contracts, the 5,000 figure that is often quoted on the Medicare side. So this all sounds good, right? The total cost of care accountability, ACO models for the primary care practices save a hospitalization, and you get to keep the savings from that. What's the fly in the ointment? And there are several. The first is and this has been again, to Medicare's credit, there's been a lot of evolution and iteration on these models, and to some extent on the commercial side as well. But one question that we have to answer here is sustainability of the models. You can't just keep getting docs running faster and faster and faster and faster to be able to earn the shared savings payouts. So how you set that benchmark, and the last thing you want is an annual, what we call ratchet, where every year the benchmark, if you do better, the benchmark comes down immediately. You can't sustain that sort of activity. So we advocated for, and Medicare adopted, this idea of a transition from first you beat yourself and then you get credit for regional bonuses, regional efficiency. And that is, I think, now widely understood on the Medicare side, this idea of, in the next contract period, 35% of your benchmark is how others in your region are doing, and then in the next contract period, it's 70% or 75%. That's a very well understood construct. It makes a lot of sense. It works. On the commercial side, we need to see more of that. The second challenge of these models is you've got to eventually go from one-sided risk to two-sided risk. And there are some who would quibble with this. I actually believe that you need to have competition in this space, just as you do in anything else. And you don't want to get complacent, and you don't want people just almost like defensively hoarding primary care docs in one-sided ACOs that don't demand anything from the docs, and they don't give anything to them either, and they're just hanging out in these ACOs. So I actually think, step up or step out and let someone else have a shot makes sense. But you can't subject small primary care practices to existential risk on the downside. You want full upside on the total cost of care, but the downside can't be bankrupting risk. And so we advocated for, and Medicare, and when I say we, I mean the whole community, including, very importantly, AFP, the Medicare responded with something called Track 1 Plus, where the upside is on total cost of care, but the downside is on practice revenue, Part A and B practice revenue. That makes a ton of sense. So if 8% of your revenue is at risk, okay, it's motivating, but it's not crippling. So that was the second important piece that, again, I'm not seeing it as much in commercial contracts yet. It's something that Medicare has led, and we need to see more of that model on commercial contracts. There are two more, unfortunately, pieces, though, of complexity that have hindered, I think, the ability of smaller practices to really grab on to these models and win in them and have confidence in them. One is, what's the right benchmark to set? And the complexity, goodness, we have some of the world's experts on these, and we still get befuddled and have trouble predicting what the benchmark is going to have been later on as it gets retrospectively modified all the time. And we had just saw this example of it when, with regional benchmarking, rural ACOs, rural physicians with rural ACOs are systematically disadvantaged in the way the current methodology incorporates them into the comparator. So there's fix-it work that needs to be done there. But the bigger issue is predictability. And my dream is, if someone says, you know what, why don't we just use Medicare Advantage rates as the regional comparators? Everyone knows what the MA rates are. And essentially the government would be saying, look, you can either keep people in where they are now on Medicare fee-for-service, or if they choose to join MA, I have to pay the MA rates. That clearly is a legitimate, valid, predictable predictor of what the benchmark counterfactual should be on the benchmark side. And I would love to see Medicare have something that approaches the predictability of Medicare Advantage for these ACO models. So I think in closing, I would say the one thing that if we want to see primary care really get the rewards of the actual value of the work that they can do, you really want primary care to be able to, if they help prevent a hospitalization, which you all know they can, if they want to help refer to the most efficient, highest value providers to benefit from that, not repeating procedures. There's extra work involved in that, but if you want to capture the true value of that, give primary care a predictable way, a manageable risk way, a companionable way for them to get a piece of the total value they create in total cost of care models.
Thanks, Farzad. That was great. And I would like to say that we have one question here about what about full professional capitation overall, with the concept that that would be less risk, but still strong incentives to reduce total cost.
You know, I don't like that as much, because one of the areas where we've seen primary care most be able to have an impact is on hospitalizations, ERs, and post-acute care. That's much easier, I think. Just doing a few simple things around increasing primary care access and focusing on the individuals during transitions and so forth. So I don't see that as being preferable. Where I do see risk is on pricing, where the thing that primary care docs can have the most impact on is utilization, how many ER visits, how many hospitalizations, and so forth. But where they can be vulnerable is if the counterparty there starts playing games with, you know, coding and so forth. So I would love to see more of a partnership with the plan, not just throwing the dollar over the fence, but more of a partnership around utilization management on the coding and hospital cost piece.
We had another question come in about kind of the data/methodology, and there's some new research out by HCCI that found that 5% of patients make up the bulk of costs are not the same people from year to year. Obviously, you're talking about the complexities around benchmarking. Is there a way to address that? Or is that just one of the many complexities with methodology?
Yeah, I think this is where I actually think having a population-based approach makes more sense. To say you have, as a primary care practice, you have your panel, you have your flock, and we're not going to try to, you know, carve out fine little pieces of it and have different, you know, a SNP for these patients and an ESRD contract, and then they go and a bundle for the, you know, like, let's take accountability for the total population. And yeah, there'll be some patients who are in the 5% this year, and it's going to be a different percent next year. And as long as you have the enduring relationship, the sticky relationship between primary care and the patient, which is considerably longer than employer relationships or health plan relationships, then that's okay. We can do the pneumonia shot this year, and we know that the patient will reap the benefit of it 3 or 4 or 5 years from now, and prevent them from being into that in that highest risk category. So I think it argues for more of an all-in pool, and potentially prospective attribution.
We have another question that just came in. Do you see a role for how pharma can collaborate with ACOs to bring more value to the primary care community and their transformation to value?
Yeah, two different ways of interpreting that. One is, are there new primary care drugs that can help reduce total cost, reduce hospitalizations, have better side effect profiles, whatnot? And there probably are some. They're not as lucrative as the oncology, you know, precision medicine type stuff, but they're probably, you know, innovative treatments for some of the things that go, you know, oftentimes unnoticed, untreated, or have a lot of ER visits, you know, resistant gout or inflammatory bowel disease or other conditions. So I see the potential on the discovery and innovation side for those pharma companies to partner with risk-taking primary care to say, do more of this and we'll share in the reduction in cost with you. They have to be at risk, right? It can't just be like, do more of this and we'll pay marketing fees or whatever. The second is in terms of retail pharmacy, and, you know, how can they help? I think improving medication adherence, medication therapy management, that's all good. One of the frustrations I have is that even when we have Medicare Advantage patients or Medicare patients with Part D plans who are obligated to provide medication therapy management, our primary care doc cannot direct that therapy. They can't say, here is my patient who needs it, go do this to this, give this patient that help. Instead, the health plans, the Part D plans, in their own infinite wisdom, decide who they want to give these services to, completely disconnected from primary care. So if it's going to be a collaboration, it's got to be a collaboration.
We have a question for Dr. Munger. In the new AAFP payment model, what is included in the risk adjustment, and how do you manage the fee-for-service component of payment?
So risk adjustment is intended to go ahead and cover not only the traditional complexity of diagnosis, think HCCs, but also we want to make sure that we're incorporating social determinants of health. Now in terms of which tool do we use to be able to pull that all together, I mean, that's still a work in process, but that's definitely something that we want to make sure that we incorporate. In terms of the fee-for-service component, those are going to be a lot of those services that are outside of the traditional E&M. So, think things along the lines of outpatient procedures, fracture care, those sorts of services that are delivered in family physician offices, but yet are more procedural in nature.
Great, thank you. We had another question come in just asking us to revisit the timeline around the AAFP model. And just as a reminder, it was approved by the PTAC for recommendation to the Secretary for limited testing. And where things currently stand is the PTAC is finalizing that correspondence that will make that recommendation. It will be then received by CMS, and there'll be a response to that. There's not firm timelines around any of that, but certainly it will be going over to HHS soon. We also know that there's been other PTAC models that have been recommended to the Secretary that are kind of sitting there for review as well. So it's really hard to predict the timeline, but the next piece of formal action is really a letter from the PTAC to HHS. I see we're about the top of the hour, and really appreciate the robust conversation from both of our panelists today. So I'd like to thank both of them for their participation and perspectives. It's an area we'll be watching very closely this year, in particular around the note around direct primary care that the CMS Innovation Center included in its request for information in the fall, and really to see how those priorities play out with regard to CMS demonstrations going forward. Just as we wrap up here, I'd like to note one upcoming webinar that we have on the schedule for Wednesday, May 9th. The topic is caring for high-need, high-cost patients, how to maximize prevention or population health-focused efforts. Stay tuned for a registration link and more information on the forthcoming webinars. We're also looking at some webinar possibilities prior to that May 9th webinar. So again, a huge thank you to our presenters and the participants on today's call. We will post the materials from this presentation along with a YouTube link for playback on our website within the next day. You'll also receive a short survey via email in the next 24 hours that seeks your feedback on today's webinar. We hope you will join us on future webinars. Have a great day.